we're going to have Dr. Rosa, who's going to talk about essentially how the cervical bone structure may have impact on the CSF flow, and then potentially the relation to MS patients.
I'm kind of the new kid on the block. I'm coming in with a little bit different observation, something that we think might have some impact with folks that have neurodegenerative brain disease. It wouldn't only just apply to MS, it will apply to others as well. My story becomes one of observation and discovery. Back in 2005, imaging 7 whiplash trauma cases, I found that 5 out of the 7 ended up having low-lying cerebral tonsils. Now, for some of you that don't understand that, some of the non-physicians, I discovered and observed that the bottom back part of the brain was coming through the opening in the skull, and that we found out of, again, 7 patients, 5 had that. So I contacted a colleague of mine who's a forensic epidemiologist, and I said, what are the chances of having 5 true Chiari malformation patients out of a cohort of 7 coming from a small town in upstate New York? And he said, pretty much impossible. I said, exactly. He said, can you get more images and let's start to see if we see a trend or not? And we did. So that led to a study whereby we ended up reviewing 1,200 cases. And we did 600 patients that were scanned in an upright posture and 600 patients that were scanned in a recumbent posture. And out of each cohort, 300 had a history of head and neck trauma, 300 had non-trauma. And what we found is that the cases that we reviewed in an upright posture with having a history of trauma, they were 4 times more likely to have low-lying cerebral tonsils than the non-trauma group. And that started to put me on this road of observation and discovery. So that later on, and this is just a little bit about the background of the paper. This is showing recumbent as a laying down MRI to those that are lay people here. The upright, of course, is upright. And we found fairly consistent non-trauma findings with the upright compared to the recumbent. But when we start getting into the trauma group is where we started to see a really large difference between the upright positioning of scanning and recumbent. And these are the bar graphs showing what we had found. This paper was published in Brain Injury Journal in 2010. And again, we see a trend where the non-trauma cases were almost identical, but the trauma, when you're in an upright posture, was significantly more abundant. So with that, we found that 1 in 4 trauma patients had the low-lying cerebral tonsils compared to the 1 in 18 of non-trauma. That led me into wanting to do research. And this is an example of what we had discovered. This is an example of a normal MR. This is what I found. This is the exact patient caseload that we did that day. 5 out of the 7 had this. In flexion, you can see those tonsils get further distended through the opening. I had met with the head of the anatomy department at Albert Einstein Medical Center, and I said to him, you're the anatomist, you tell me, is this something that's plausible due to trauma? And his answer was, he called this a cork in the mouth of the bottle syndrome. He said it's not due to the traditional Chiari malformation where you're at birth. Unfortunately, you have a flatter back of the skull called the posterior fossa. When that flat posterior fossa is involved in a Chiari malformation, the internal skull volume is narrower, smaller, and the chances of the distension of the bottom back part of the brain with cerebral tonsils would be higher to come out. Usually they cite some form of a trauma initiating it to come out. But this was something that we found. These are not Chiari malformed patients. These were traumatic-induced cases that we found. So that led us on to, again, observing these are all the cases from that day. This is a difference between a patient laying in a recumbent posture. We sat him right up and did him in an upright posture. We found that for some reason gravity is going to affect the distension or the settling of those cranial elements. And that, of course, led me on to doing a research study about 3 years ago. We did 43 cases. It was a random controlled crossover study. And to my knowledge, we had gotten 43 cases of confirmed head and neck trauma. Now, what I didn't realize is that out of the 43 cases, 4 had MS and 2 had Parkinson's. And when I went and started looking at the imaging studies after we completed the study, we started noticing that there were common threads. And the common threads were the following. All of them had a misalignment of C1, C2 at the skull base. All of them had low-lying cerebral tonsils. All of them had obstructed spinal fluid flow. And I found it very interesting that when I compared the images, and they all have these common threads, I started to say, well, maybe we need to start separating out the neurodegenerative brain disease cases. Maybe we need to look solely at MS and Parkinson's, which is what we did. So from that point, we started doing these flow studies. Now, what we found with these flow studies is that we started observing that spinal fluid can aberrantly flow in such a manner that it can actually cause turbulence. In some cases, we started noticing that it was causing back jetting and literally impacting the brain and brainstem in places that we later found out had lesion load as it pertained to MS. We also found in the Parkinson's cases, which I'll demonstrate in a moment, that the aberrant flow pattern started to go retrograde up in towards the substantia nigra. So we started saying, is this part of a piece of a puzzle that maybe we have not really understood or looked at before? And of course, this technology that we're using today has allowed us. So this was a very compelling study because this was the first study that I did, or that I observed, that actually showed spinal fluid impacting brain tissue in a manner that you can see it causing the tissue to move. So I'll bring you right here, right in that area. That's a cerebral tonsil. And when we put this into a movie loop, you're going to start to see that tonsil is starting to wag like a dog's tail with every cardiorespiratory CSF flow cycle. Y'all see that? So that showed us that spinal fluid can impact tissue and certainly can move it. Y'all see that? Okay. So, we then went ahead and started to look into other types of issues. So this is going to be a case right here of a young man who has MS, he's in a wheelchair. And when he first came to us, what we noticed on his study before we treated him was the following. When you look at the level of the brainstem, what you're going to see is, you're going to see a signal intensity right within this region. This is the aberrant spinal fluid flow pattern, and it's presenting as somewhat impacting against the brainstem, right at the level of the signal intensity. This was before he was treated. This was after the treatment. We'll explain that a little bit after. This was within about an hour. And what you're going to see when we put it side by side is you're going to see a diminishing of that signal intensity after treatment. And what you're seeing now is a more stepwise fashion or smooth transition of the spinal fluid anterior to the brainstem and cord, rather than one of impacting, and you see the signal intensity has gone down. So I'm thinking to myself, okay, that doesn't look like it should be too healthy for that tissue. So what we did was we went in and we reviewed his actual brain MRI. And when we reviewed his brain MRI, and Dr. Scalfani, I want to bring your attention to this one. When we looked at his brain MR, what we found was the following. There's his lesion load, right at the level where that spinal fluid was hitting that tissue. We also see, look at the aberrant tension and stress on the spinal cord. That also is creating stress and tension on the vascular supply. We have numerous images showing this. Time unfortunately won't let me do that, but very compelling. So we then went ahead and looked at other cases. Here's another case. This happens to be Sharon Richardson, my gracious person that invited me to come speak today. Her grandson, 11 years old, what we found on him, he was found at 11 years old to have lesions, MS lesions. So here again, we're going to demonstrate what we saw before treatment, and then we'll demonstrate what we saw after. And when we look at the pre-study, there again, you're going to see a signal intensity right at the back portion of the cerebral. And what we did is we did a follow-up study within, I believe, about an hour treatment. And this is what it was like within an hour. And what we see is we see a calming of that signal intensity. Want to see the difference? Now, when we went in to look at the levels of where that signal intensity was, what we found was the following. If we go ahead, the left side would be the scout view of what we're looking at. These are the things that we're looking at. These malrotations. This is C2 relative to C1. And what you'll see is there's what we call a rotary misalignment of C1 and C2. Here is C2, and here is C1. As we go up and we start to explore the level where the signal intensity was showing up, that's where you start to see the signal intensity. There's where you start to see your lesion load, right at the level where that signal intensity was showing up. So we started to question, can aberrant spinal fluid flow patterns affect brain tissue, spinal fluid? We then went ahead and obviously did further studies. One of interest is, this is a before and after study of our host. And what you're going to see here is Sharon had a stent put in, a very successful stent. And this was her before we treated her. And what you'll see is the stent is essentially not moving any fluid. And this was confirmed by, I believe, ultrasound. Is that correct? So this was before treatment. I will draw your attention also to these vessels. You'll see how they're off-center. And this was her after treatment. If we put them side by side, what you will see now is there is fluid moving through that stent. You're also going to see, instead of these vessels being offset, they're leveled out. And we're finding this correlation between correction of the C1 vertebra malalignment and improvement not only in flow, but also position. We then went ahead and we had a Parkinson's case. And this was one of the most dramatic cases of spinal fluid turbulence that I had seen. And this was a case that Sharon was with us that weekend. And what you'll see here is before treatment, there's that spinal fluid flow pattern right in there. It looks like an upside down vortex of a tornado. That is happening every cardiorespiratory cycle. And what you'll also might notice, the interventional radiologist probably notices more than I would, but there's a retrograde flow of that spinal fluid. It's a very substantial artery is, and that aberrant flow pattern is redirected or diverted that normal flow pattern of spinal fluid. So this is him before treatment, this was him after. And this was a very interesting study because we had finished and had gone out for dinner. I got a phone call to show you the difference. Now what you're seeing is a decreasing of that turbulent flow pattern, but you're also going to see a more return of the normal CSF flow pattern in the downward manner as it should have been, as compared to the pre. So ironically, this patient called up, actually before he left, when we put him back in the scanner, he said to the technician, "Can they hear us?" And she said, "No, why?" And he said, "Because I think they're all crazy." He said, "I didn't feel anything, and I don't know how this is going to work at all." So about an hour after he left, a phone message came in. He wanted to speak to us, and he called me up to say he apologized for being so skeptical, that after, within an hour of him driving home, he had felt about the best he had since he had been diagnosed with Parkinson's. So, as I say, I do things of observation. I don't fully understand everything yet, but what we're seeing is that when we see these changes in these patterns of spinal fluid flow, the patients are reporting feeling better as they do with CCSVI. We're working on getting a lot more numbers than we presently have, but this is very compelling information. Another example, this is a patient before treatment. This is a patient after treatment. Here it is before the treatment. This patient had extremely low-lying cerebellar tonsils. And what you're seeing here, there's that signal intensity. There are the tonsils. They are literally restricting the normal flow of spinal fluid pattern. And then after signal intensity has quelled, and the cerebral tonsils migrated up dramatically. So the only thing we did interveningly was take a C1, C2 malalignment, correct it, and the cranial elements migrated up. And this is where we're seeing these improvements in the spinal fluid flow. Now, we also have noticed, here again, this is a case of a gal. She doesn't have MS, but she was a trauma case. And this is her before treatment. She had 18 millimeters of cerebral tonsil ectopia. That's her on the left. That was her on the right. Now, the tonsils didn't come up a lot, but she had suffered with headaches for 3 years. And after the treatment, the headaches abated. And when Dr. Scalfani had spoken just a moment ago about the potential of vessels being obstructed or compressed, here we have a perfect example of exactly what he had just described. This is an image here. Here again is these are the vertebral arteries. Those are the tonsils. That's how far down they're coming. And this is the other image where we actually see the vertebral arteries actually deforming the cord. They're actually compressing the cord. So what we did with her is that we went ahead and we rendered treatment. And this is her imaging flow study before. And this is her imaging flow study after. And what you're going to see on the pre-study is there's actually, these are the vertebral arteries compressing and deforming the brainstem. This is before treatment. That's every cardiorespiratory cycle. So, can there be a physical compression on vessels, arteries and veins? We think so. We think so because we're seeing them both inside the canal. We're also seeing in the arteriovenous system, which would include the jugulars as well. So this is her before treatment, and this is her after. And of interest, we can see now the morphology of the cord is more rounded than triangular. And we're also seeing a little bit better, here again is the movement of the carotid, the jugulars, the displacement of these after we see they're more level. And we're also seeing an improved flow pattern on the jugular on that side after the treatment as well. So there's something with the mechanical misalignment of the cranio-cervical junction that we believe might be part of this puzzle. Somehow it's affecting CSF, somehow it's affecting the arteriovenous system. So these are just static images demonstrating the actual misalignment structurally of C1 relative to the skull. These are the tonsils. This is a C1 misalignment. That C2 before treatment. We can see oftentimes the cord can be tethered by the dentate ligaments. We believe they're involved. That was after treatment. That was within an hour. This is an MS patient. That's an MS patient. You see these malrotations? I don't think anyone's really been looking at that. I can't imagine that they're not affecting the cord. The dentate ligaments will pull on the cord. They pull on the spinothalamic, spinocerebellar tract. Spinocerebellar tract is responsible for lower limb function, bladder. All these things might be comorbidities that could be affected by that. Spinothalamic tract is responsible for sensation and touch, pain and temperature. Dementia. We just treated a very famous dementia patient, suffered for 4 years. We corrected his atlas. It restored his spinal fluid flow. He had pooling in the frontal area of the brain. Within a week, that pooling had stopped. And it's the best he's felt in 10 years. His brain fog had stopped, and he's doing wonderful. Parkinson's, before treatment, after. Here's what I mentioned about, not only can we see the displacement of the vessels, but look at how the muscles are being affected, as Dr. Scalfani said, some of the other presenters discussed that today. This was after treatment. This is the transverse process of C1 compressing a vessel. This is something that I've got all these images, and it seems like every time I learn more about CCSVI, I start looking back at the images I've done 2-3 years ago, and I'm finding data that might be part of the puzzle. This is a patient before treatment. That's after. So we are affecting vascular supply. Somehow that cranio-cervical misalignment corrected is improving vascular function. Pre-X-ray of this patient before treatment. Post-X-ray, There is a severe scoliosis, caused a lot of cord tension. We do something called an image-guided atlas treatment. This is the instrument that we use. It's not invasive. There's no pain involved. We don't manipulate. We don't snap, crack, or pop the spine. Not that I'm against those that do. Essentially, what we do is the following. The instrument just essentially generates a gentle tapping. Obviously, more involved in it. We use three-dimensional X-ray and MRI to get the exact vector that we use to set the atlas and C2 back in alignment. And we believe that the future will hold using this type of advanced imaging to help diagnose patients. Maybe we can work collaboratively with how the CCSVI assessments are being done. Thank you.